Valorant is excited to have you here today. Thanks also to Allelica for taking the time to share some of its amazing story and vision. For those of you who don't know, Valor Ventures is a lead investor at seed stage, the first professional round typically. For Valor, for venture, seed has always been the biggest returns generator. Valor is looking for world changers. We invest without bias by activating inclusion at each phase of development. I'm pleased to have with us the CEO and co-founder of Allelica, Giordano Botta, who joins us today from Rome, Italy. And he's going to talk to you about what's known as a polygenic risk score and the company formed to bring that to market, Allelica. With that, Giordano.
Hi, everyone. Thanks, Gary. I'm Giordano Botta, the CEO and co-founder of Allelica. I have some slides that I can go through. Also, if you have any questions while I'm presenting, please feel free to ask in the chat. I'll be really happy to have this kind of interactive conversation as well. So today I want to talk about the next generation of clinical genomics, where genomics is becoming mainstream. I want to start with saying that healthcare is a broken system, and this is very scary when we see at the latest estimates, where about $2,000 per person and a total of 650 billion a year are wasted because of lack of access to care, people that they need, and also because of the majority of individuals that need to be treated are missing by traditional risk assessment. This is even scarier if we look at the data behind, at the hundreds of thousands of cases that can be prevented, such as, for example, the cases of CAD, that is a coronary artery disease, so the heart attack, but also the deaths of breast cancer and prostate cancer that can be dramatically reduced in case the disease is detected earlier when it can be treated. And so we need to act now, and we need to accelerate the transformation that is happening in the healthcare, where we are moving from a reactive medicine to a proactive and predictive medicine, where prevention is considered as a tool, as an action that cannot be postponed or neglected. And also moving from a one-size-fits-all approach in drug prescription to a personalized way, where the genetic component of an individual is considered and when a drug is prescribed. And this is possible thanks to development of new technology, new business model, and new policy that need to be working parallel to realize this transformation. And then also the infrastructure are changing, because we are moving from an institution where is centered, where we have a decentralized model with several facilities that are hyper-specialized and offer also service for people that did not develop the disease yet, such as breast cancer center or radiology centers, where they can really make in action the preventive approach. And then we are also moving from a paternalistic way to disclose results and disclose information to patients to a way where it can really empower individuals to make informed choices that also they can last over time. And also, very importantly, we are moving from a volume-based way to consider the outcome of healthcare treatment towards a value-based, where the value and also especially the reimbursement is based on the health outcome and not on the number of people that are treated. But how can we make this happen? So what are the main pillars of this transformation? So no surprise where disease prevention plays one of the most important roles. And disease prevention is based on healthy lifestyle, where each of us is responsible for it, and also on screening and procedure and actions that can be taken with the help and with collaboration of our doctors. But there is a problem, because preventive models that are often used by physicians to identify individuals at high risk, they do not well for a vast fraction of the population. So just for give an example, for a heart attack, up to 30% of the individuals are not identified at high risk when they have a heart attack. So up to 30% of heart attack cases happen in individuals without any apparent and obvious risk factor. This is also true in cancer prevention, where about 30% of cancer are identified and detected at late stage 3 or stage 4, where the chance to survive to the cancer are much less. For example, 81% of individuals survive in 10 years after a diagnosis of cancer, while just 26% survive a diagnosis of cancer at stage 3 or 4. And this is also true, even more accentuated in breast cancer, for example, where survival is as high as 98% if you can detect the cancer earlier, while if you identify the cancer at late stage, the chance of survival decreases as low as 60%. So what is missing in these models? Why they're not effective as they should be? To understand that, we need to consider that common diseases such as breast cancer and prostate cancer are caused by a combination of factors. And traditional risk assessment have been very good in identifying common and traditional risk factors such as alcohol consumption, lipids level, or sedentary lifestyle. But genetics component of the disease has been neglected so far, or has been considered only using mutations. And mutations are errors in our genome that are useful just for a very low fraction of the population. So we need to move from the use of rare mutations to the use of common variations. So these are two different components of the genetic code that we each of us have. And the common component of the disease can be captured by the polygenic risk score. Polygenic risk score is a score based on genetics data. But to really understand this score, we need to understand the continuum on genetic variation of human disease, where we have variants with a very high effect, but they are very rare, such as, for example, mutations that are very well known, BRCA mutation that increase the risk of breast cancer, but are present just in 0.3, 0.5% of the women. While in the opposite spectrum of the distribution of the frequency, we have common variants that are polymorphism, that are variations that let us, for example, have different eye color or different shapes of our face. And this can be captured by polygenic risk score. A polygenic risk score, so high polygenic risk score, is present in a much greater fraction of the population, from 10% up to 20% of the population. So in order to really make effective the risk models, we need to include also this component of the genetics continuum of human disease that has been neglected so far in risk assessment. But large biobanks have allowed the development of polygenic risk score. So big data has really enabled the development of polygenic risk score. And we have seen a big movement across the entire world of collecting new data and using large prospective data set in order to identify this component of the disease. But how can we build effective polygenic risk score? We need first to identify a discovery data set. Then we need to try different algorithms, including machine learning algorithm, Bayesian algorithm, and this because each disease has a different genetic architecture. So this is a complex problem to solve. And then we need also validation dataset and testing dataset to rule out overfitting, because we need to develop model and be sure that this model work well across different datasets. And then we also need to deploy this algorithm into the healthcare. So we need first to generate genetics data, then we need, and since we are using common variants, we can use an inexpensive and affordable way to access genetics data. This is a big paradigm change in genetics and in genetic testing, because we don't need to use expensive procedure and expensive technology. We can use, for example, microarray or low coverage whole genome sequencing. Then we can use software to align this genetics data to the polygenic risk score panel that we have developed previously. Then we also need to identify the percentile of the distribution where an individual lies, because the score is based on a score composed of the entire spectrum of the population. And then we need to move from percentile to absolute model and absolute risk. And then where we can really use this information. So it's a complex problem that requires expertise in software engineering, statistical genetics, and also public health. That's why we joined forces among 3 founders to start the company back in 2017 with Paolo, who is a software engineer, and George Busby, who is a statistical medical geneticist that with more than 20 years of experience in research on statistical medical genetics, and a high-end biologist with a PhD in public health. We also put together a medical and scientific advisory board in order to identify the best approach to disclose this information and to be sure that the algorithm developed with this such big data set are really effective in the clinical practice. So for example, we joined forces with Robert Green, that is a professor of medicine, genetics medicine at Harvard, Honora Burhasna, that is a clinical director of the Genomic Institute at Mount Sinai. And also with Bjarni, who is the researchers in polygenic risk score method development. So we wanted to have the best advisor in both the method development and also in the clinical implementation of this algorithm. We are very active in doing research with different research groups across the world, and also working with healthcare systems and pharma companies. We recently got a grant with the University of Sydney of about 3 million to validate the polygenic risk score for coronary artery disease that we have recently developed. But why is it so important to apply this polygenic risk score, so the polygenic risk score for a coronary artery disease or for a heart attack, into the clinical care? Because polygenic risk score stratifies risk better than any of the traditional risk factors commonly used in the clinic so far. So better than LDL cholesterol, the HDL, and also the ratio between those. And also because individuals at high genetic risk, so with a high polygenic risk score, are invisible to the traditional risk assessment, because polygenic risk score is not correlated with any of the traditional risk assessment commonly used into the clinic to assess risk. And also we asked if there was, or which was the interaction on the relation between polygenic risk score and the main cause of plaque formation in our arteries, so the LDL cholesterol, the bad cholesterol. Since previous studies have shown that individuals with a high polygenic risk score, they have higher plaque burden, so they have more plaques in their arteries. And also, Natarajan and colleagues shows that individuals with high polygenic risk score, they have greater benefit when they take statins, so when they take the drug to reduce the LDL cholesterol. So we assess what was this relation, and we identify an interaction between LDL cholesterol and polygenic risk score. This is one of our study that has been published on Circulation last year, where we show that the risk of heart attack that is conferred by LDL cholesterol depends on our polygenic risk score. So the LDL cholesterol does not affect everyone the same, because the risk that it confers depends on the polygenic risk. And to identify that, we divided in 3 different polygenic risk score groups, so low polygenic risk score, intermediate, and high, about 3,000 heart attack cases and more than 150,000 controls in a prospective longitudinal clinical study. And what we have found is that when we stratify further these groups in LDL groups, we found that individuals with average LDL, that is the LDL level between 130 and 160 milligram deciliter, that is the LDL level that is most common observed in individuals. These individuals, they have the same risk of those with hypercholesterolemia, so with LDL above 190. And also, we found that individuals with high polygenic risk score but low LDL, so optimal LDL, they can reduce the risk to optimal, reduce the risk as those with optimal cholesterol and also without high polygenic risk. So the interaction between LDL and polygenic risk score is effective only when the LDL starts to increase up to non-optimal level. So this means that genetics is also actionable. So genetics is not our destiny. So even if we have a high genetic risk of heart attack, if we optimize our LDL, we are safe. And then we identify also another population, this is very important for research purposes, that is not affected by the atherosclerogenetic effect of LDL. So even with a high LDL level, they never have the, let's say, dangerous increase in risk. So what we propose is a new lipid management paradigm, because now the guidelines, so the American Heart Association guidelines, they suggest to use statin, high-intensity statin, to all these individuals that have LDL greater than 190. But we just found that there are individuals that have the same risk with just 130 LDL cholesterol. So for individuals with a high polygenic risk score, there is no any need. They do not have to have such elevated LDL. They need to reduce their LDL, or in case also use statin if they cannot reduce the LDL with the diet, for example, even at lower LDL levels. And also, polygenic risk score can be used to guide treatment in individuals at borderline risk. So individuals that have average risk, where physicians, they don't really know if they need to wait or they need to intervene immediately to reduce their cholesterol. And for example, it was published by Aragam and colleagues by the Journal American College of Cardiology, a study where they show that individuals at high polygenic risk are not identified by the traditional guidelines, but they have more than twofold increased risk. And this twofold increased risk is considered to be enough to have a risk-enhancing factor. So individuals with a high polygenic risk score, they have a risk-enhancing factor, but are not treated accordingly with the current guidelines. So they propose to use polygenic risk score as an additional risk-enhancing factor in individuals at borderline or intermediate risk. So we asked if this was affordable, if this was also cost-effective. And then we perform a study in collaboration with Illumina, that is a company leader in producing machines to sequence the genome. We performed a study led by our health economist, Dr. Deumujwara, where we model the use of polygenic risk score as a risk-enhancing factor in the pool cohort equation, that is the model used in the clinical care at the moment to identify risk of heart attack. And what we found is that it's not only cost-effective, but it's also cost-saving. So while we are improving the quality, that is a quality-adjusted life here, so we're improving health outcome using polygenic risk score as risk-enhancing factor, we are also saving money for each individual that is tested. And this varies from $50 up to $150, depending on the predictive power of the score, so the quality of the score used in a 5-year time horizon, and $150 up to $450 in 10-year time horizon. And then we also develop a calculator to let the physicians empower their patients and let them understand that the genetics is not their destiny. So they can show to their patient that acting on the traditional risk factors, such as total cholesterol, HDL, or smoking, they can reduce the risk, as you can see here, even in presence of high genetic risk. So this is an individual that has high genetic risk, is at intermediate risk, and also has a very elevated lifetime risk, but acting on the traditional risk factor is able to reduce the risk to the average population, despite a high genetic risk. Then, what are the applications that polygenic risk score can have in cancer? So, unfortunately, up to 16% of breast cancer cases are identified at late stage 3 or stage 4, where mortality is extremely higher. And this despite the massive screening that is that takes place in a woman that have 50 years or older, so starting at 50 years. So we shouldn't expect to have such a large fraction of cases detected at late stage. But this because the year of screening, so they're having a fixed year of screening, is not the right way to go, because genetics data, so using polygenic risk score, we can identify women that have the same risk of a 50-year-old woman, even 20 years earlier. So there is no any reason why a 30 years woman should wait 20 years before start to screen and have her MRI done while he has the same risk. And also, it's possible to identify better the risk using absolute risk models, incorporating polygenic risk score with age of menarche, for example, or the number of children, so with the traditional risk factors, and using polygenic risk score in this absolute risk model. And then we mentioned before the BRCA mutation. So BRCA mutation are also considered as a very strong risk factor, and some women also decide to have invasive procedure such as mastectomy to reduce the risk of having a breast cancer. But polygenic risk score is able to modulate the risk conferred by these mutations. And what we're showing here is that women with the low polygenic risk score, they are protected by the effect of BRCA mutation. So they do not have such high risk as the average woman with the BRCA mutation. So potentially there are hundreds of thousands of mastectomies that can be avoided over 10-year time, just considering the polygenic risk score. And this is also true with the moderate penetrance genes that are currently used into the clinic to assess risk of breast cancer. Then in prostate cancer, it's possible also to stratify individuals based on their polygenic risk score. And for example, in carrier of pathogenic mutation, it's possible to identify individuals from about 3% lifetime risk up to more than 80% lifetime risk. But unfortunately now these individuals are considered to be all the same. So all these individuals, they have the same preventative measure. And also individuals without any any rare mutation, it's possible to stratify the risk from 1% up to more than 40%. And this is extremely important in a disease where the screening is really ineffective and approximate, such as, for example, the PCA. So we don't have a good screening in place. So here, polygenic risk score can really make the difference in reducing the onset and the burden of this cancer. Then there is also a lot of work to do in order to return these results in a meaningful way, because it's not the percentile of a score that matter, but the risk that it confers. So in our report, we return the absolute risk of developing the disease, and also, to be completely transparent, the predictive power of the score, and so the stratification of the score, so what is able to achieve. So in this way, we are sure to understand where the individuals is located in this risk distribution. Then I
have a question from the audience that might be a good place to ask now, Giordano, if I may.
Absolutely.
Have polygenic risk scores been applied yet to ovarian cancer or skin cancers?
Yeah, so these are still on the research stage, because in order to develop a very predictive polygenic risk score, we need to have a lot of data. So we need the genetics data of many people, and the more common the disease, the faster we can move, because we can have more samples to feed the models. And some cancer, such as, for example, skin cancer or ovarian cancer, we do not have enough data yet in order to really identify a very powerful risk increase and be able to use this information to the clinic. And so also in, for example, in melanoma, there are several studies that are being carried out now, but still we don't have a polygenic risk score that is really effective, because what is really important to stress is that polygenic risk score is not a wellness genetics trait or a wellness genetics technology. So we don't use score that increase the risk by 10% or 20% into the clinic, because, for example, if a disease has a prevalence of 1%, knowing that someone has a 11% of the disease or 1.1% of the disease is not enough. What we want to know is an increased risk of threefold, fourfold compared to the average. So there is a much potential, and this is we can achieve this increase in risk prediction if we join data. So in fact, I'm going to touch this a bit, because unfortunately there are so much data collected that are not used as they should. So there are very large consortia where they collected several data sets, but for privacy and regulatory reason, they cannot be shared. So there has been a lot of research, and we also developed method to allow the sharing of this data set in a more effective way, because we urge the sharing of this data. So there is also a question of how patients can be enrolled in this study. So there are several initiatives. For example, the eMERGE dataset, where several healthcare systems across the study can they accept individuals where they link their genetics data, so they pay for their genetics analysis, and they link the electronic health record to this genetics data. So they will follow over time, these individuals, and in this way, we will be able to identify the genetic component of these diseases. So I can share this information also if interested. So there is a big problem of health disparities among human ancestries. This is a well-known problem where non-European ancestry, they have less access to treatment or also to preventive treatment, but also models based on non-European ancestry, they are less predictive. So, for example, this model here, this is a paper published in 2021 on Circulation, where it showed that individuals of South Asian ancestry, they have higher incidence of disease, but the pool cohort equation, so the risk model that is currently used when you go to your doctor, what they use to identify if you're at risk or not are the pool cohort equation, but this model do not work well in all ancestry. So, for example, there is the pool cohort equation are not able to identify the increased risk in South Asian individuals. And also, this is a well-known problem also in genomics, where, as you can see, there was an explosion of genomics data since the 2017, 2018, but this was not proportional among all different ancestors. So now we have hundreds of thousands, hundreds of millions of association analysis performed on individuals of European ancestries, and 80% of the data is from European ancestries. So we really need to accelerate the collection and the use of genetics data from non-European ancestries. And so how we can join forces in a very regulated, very strictly regulated field such as genomics, where the data is very sensitive. And there are several places and infrastructure where we cannot, that they do not allow the sharing of the data. So a way, a technology that can be implemented is the federated learning, where it's possible to share the value of the data without sharing the data itself. So where the model is run in the database containing the data set in the premise or in the facilities where the data is stored without sharing the data. Then just the model, so the outcome, the weight, so the effect of the risk factor is shared and then combined. This is a very effective way to improve the predictive power of predictive models that was used, for example, on our mobile phone to improve the way that, for example, the text is suggested when we type on our board, on our phone. And in order to accelerate the sharing of the data, Allelica launched this Polygenic Risk Score Alliance, where we first send the polygenic risk score that we have developed to each hospital or to each genetics lab. And then as new data are generated that are collected in each hospital, there are models are run internally without sharing any data. What is shared is just the outcome of the model, so the weights of each output. Then we combine with the models that we develop all this data set, and we validate these models in external data set. Then next, we send back an improved model to the hospitals. So in this way, we can improve the predictive powers in an iterative fashion without sharing data and maintaining the privacy of this data. So in order to really make clinical genomic mainstream, we need to accelerate the adoption of polygenic risk score in the clinical risk assessment. And we need to move from the use of only rare mutations, so rare genetics variants, to common genetic variants to really be effective in the risk assessment. And this will allow the realization of medicine that is not just reactive, but is proactive and is efficient and effective in being proactive. this end. So thank you for the attention.
Thank you very much, Giordano. I know that's a meaty subject. You do a fine job of it, but if there's any questions, we'd like to entertain those now. If you have questions about sort of the company's technology and or business and so forth, we're happy to talk about that, but we want to make sure we cover an understanding of its products and what it does, first and foremost. The dream of personalized medicine, precision aligned to you, is the dream that this company talks about. It is the vision that those that are behind the polygenic risk score see. We are extremely excited at Valor to have partnered with this, one of the first 3 companies to really ever have such a product. If there's nothing further, I suppose we can give back time to the audience here. Oh, sorry. How close to commercial deployment? It is already commercially deployed and being used daily, to a very, very significant degree. I don't want to talk about the company's revenues, but it's far from zero. Its first year of revenue generation was just the end of 2020, but they really grew tremendously last year and are on track to grow many hundreds of % this year. So in certain fields of clinical practice and in certain research settings, it's already in commercial use daily. Hundreds of thousands of tests a year. Thanks for the question. What countries are you deployed in? Is that the next question from the audience here, Giordano?
Yeah, you are active in the US, in Europe, in Asia as well, and Australia. So you are active in, let's say, all continents. What is really important now is to educate the physicians and all the stakeholders on the use of these technologies. And this is, we see, countries moving at a different pace based also on how participated are physicians and also genetics lab in providing this testing.
Giordano, thank you very much. If there's not a follow-up to that, I'll go to the next question. Are these scores shared with the patient, or is this just for the physician?
This is a physician order test where a physician has to order the test first and then share with the patient. So it's not a consumer product. We cannot sell this, but we believe that it's really important that the physician play a role in communicating the result of polygenic risk score, because then they can act together with the individual.
But it's been designed for the physician to share with the patient.
Exactly.
And that is the clinical practice at present. Now, I've got a really big question for you from the audience here. How fast do you see us moving from reactive model to proactive model?
Yeah, unfortunately, everything in the healthcare is slow, but it's a matter of time, because all the data that matter for the payers are there. So the cost effectiveness, the health economic study, they show that the polygenic risk score and using this technology in a proactive way is cost saving. So it is frustrating, because it will take 3 to 5 years before this will be as common as the blood cholesterol test, for example. But this will be a big revolution in prevention, because there are several layers of that need to be educated, and also need to change the way they work and think about prevention. But the important thing is that the data show not only the health benefit, the improving in the quality of life, but also that this solution is not only cost effective but also cost saving.
It would seem that 3 to 5 years is fairly fast to move from reactive to proactive, and what we can't talk too much about that Allelica has going for it, but it helps you see, the audience here, how this can be deployed globally rather quickly. We're in a letter of intent moving to full global commercial deployment with a leader in gene sequencing technology that will take this to market across the globe, with us supporting them doing so. So the ability to get it deployed globally is, really dependent upon much more than just Allelica. And it has global legs already. That's just one of the several partnerships. But since we've invested, the company has this partnership. So there's a way to get it clinically in practice globally a lot faster than you would think if you were just imagining Allelica doing it with its own 2 hands and feet. Any further questions? Giordano, how has the the COVID accelerated or decelerated or impacted your business is a question one of the people had.
Yeah, so it's kind of difficult to really understand the effect, because it was negative for sure from in respect of building a relationship with people at conference, because one of the best channels for us in start working with the large accounts was a conference, because then we can really build a relationship with people. But at the same time, was very helpful and useful to have all the global talents available to work together. So this has a very big shift in the person and the talents we can work with. So working with people across the world is not is something that is extremely easy and common now. Before was not.
Well, that's so far the last question that I think we have. I really appreciate you taking the time, Giordano. Thanks to the audience for joining. Again, Gary Peet, General Partner at Council Ventures. Giordano Botta, co-founder and CEO of Allelica. If there's nothing further, folks, we'll give you back a few minutes to your day. Thanks very much for attending. We appreciate it. Oh, wait, we might have one more. We might have one more. Let me check. Don't want to go too fast. One of the questions was, how do you collaborate with pharma? How does this relate to pharma?
Yeah, so there are 3 components of the work with the pharma. So one is to identify individuals that benefit the most from certain drugs, especially the very expensive drugs. So to accelerate also reimbursement for these drugs. The second one is to stratify individuals in the clinical trial. So having this additional risk factor, they can have more power and understand better the effect of the drug, and so monitor better the trial. And also third component is to identify drug target and also drug repurposing, because we can identify what are the metabolites involved in complex diseases. And this was extremely difficult to do before. And so now with polygenic risk score, we can identify what are the metabolites involved in certain diseases, and see if there are already some drugs that, for example, can be used to treat that disease that before was we just didn't know that was possible to use it, or otherwise to develop new drugs based on these new targets.
One other question relates to payment, what we call in America reimbursement for this. I think, Giordano, you have, the health systems and physicians regularly using this test for reimbursement in Europe. I think in the US, the key step is always having the CMS, Medicare, Medicaid services reimbursement yet. Giordano hasn't sought that yet in the United States. So I don't think that we have it yet, having not sought it yet. But it's clearly a part of the plan.
Yeah, we are working on it, and we have all the data available to show. Now we are working also with the FDA to build the code, because it's a process, because we need to build the entire infrastructure around the reimbursement, starting from the code, and then for building all the evidence and putting all the evidence together. But we are working on it.